We have Anan.
Bonjour.
Okay, so let's move to the next chapter, which is maybe one of the biggest problems for with endometriosis, and I want to speak on adenomyosis. Bonjour, Anan.
Bonjour, Professor.
How are you?
Good.
So, Anan from Dubai will tell us everything you should know on adenomyosis. Okay. Thank you,
hope
Anan.
so. Thank you for you, Professor, as usual. I'm really honored to be part of this course. And I grabbed the opportunity to express my sincere condolences for the loss of Professor Amo, specifically to you, Professor, and to all all the attendants in this room. It's really a big loss. So I will start sharing my screen. As said, I will be talking about adenomyosis, more specifically the surgical treatment, as we are in a surgical course. So I guess everyone in the room knows what is the definition of adenomyosis, which is the benign invasion or the infiltration of the myometrium by endometrium, glands and stroma, producing a local inflammation and diffusely enlarged uterus with endometrial glands surrounded by hypertrophic and hyperplastic myometrium. So back in the time, it has been the disease of multiparous. You are seeing my screen, right?
Yes.
It's perfectly well. So back in the time, this disease was the disease of the multiparous late 40s. After completing their family, there was no need to establish a pre-op diagnosis. And most of the data we have is from a retrospective diagnosis on specimen of removed uteri. And the only definitive treatment at that time was the only hysterectomy. And we never talked about adenomyosis as a cause of infertility. However, the epidemiologic scenario has completely changed over the past 2 decades. And adenomyosis is now the disease of young ladies at the age of reproductive life. So this paper for 2007, Kearns and co-worker has looked retrospectively at the MRI of patients with endometriosis, and they found that adenomyosis, which is defined by a thickening of the junctional zone, may develop much sooner in life, particularly in patients with endometriosis. Moreover, and when we come to the fertility outcome and impact of adenomyosis on the reproduction, this paper in 2022 from France, where they recruited 220 patients with confirmed diagnosis of endometriosis on histopathology, and they included only patients who had pre-op MRI where they diagnosed adenomyosis. And they found that patients with endometriosis only, within 4 to 5 cycles of IVF, they have up to 85% of chance to go back home with a live baby. However, patients on whom we have the association endometriosis and adenomyosis, this chance drastically reduced to 50%. Another endpoint of this research that they found in infertile patients, adenomyosis and endometriosis coexist in up to 80%. So obviously, now we are talking about a patient on whom the fertility preservation is required, and probably we ignore the real incidence of adenomyosis among this population. It's affecting a central reproductive organ, and it is more relevant in the setting of fertility and raise the difficulty of diagnosis and management, because till now we don't have a universal guideline how to manage these patients whom they are desiring fertility preservation. And we started talking about alternative to hysterectomy or uterine preserving surgery in adenomyosis. And we have always to remember that the aim of any surgical conservative treatment is to excise the diseased tissue while preserving the integrity and the functionality of the organ. However, we know that adenomyosis infiltrates the myometrium without a clear border, and the excision of adenomyosis is associated with the inevitable excision of diseases of healthy neighboring tissue, which may be somehow destructive to the uterine wall. So we have always to balance the advantage of being radical towards this disease against the disadvantage of leaving a defective uterine wall, which may lead to the functional hysterectomy. At the end, we need to preserve this organ to carry a baby. So the main principle in the surgical treatment of adenomyosis is do not harm. Moreover, as said earlier, that we have to be ready to deal with the two conditions you have seen over the past 3 days, how complex is surgery for deep infiltrating endometriosis as shown in this case. So you have to be ready to deal with the two conditions at the same time. You can see that the sigmoid here is attached to the torus and covering a focal lesion of deep infiltrating endometriosis, continuing upward with a diffuse and focal adenomyosis. As said, that the coexistence of adenomyosis and endometriosis is found in up to 80% of infertile population, who are the main target of this type of surgery. Here, it's an overview of conservative surgical treatment for adenomyosis, and we can differentiate, as their name suggests, complete excision, aiming for a complete removal of the adenomyotic tissue, obviously targeting more or less focal lesion, and the cystectomy, which is mainly concerning the cystic juvenile adenomyosis, disease mainly of adolescent to end of 20s. And we have the partial excision, which is a cytoreductive surgery. So through a different video from our cases, I will be illustrating different technique. So Japanese people were the first who started talking about surgical conservative treatment for adenomyosis, and that was done mainly via laparotomy. On the upper part of my screen, we have the triple flap. The triple flap, or the overlapping flap, is in relation to the reconstruction technique, but the excision technique is almost the same in the two techniques. technique. And in both cases, the uterus is bisected in the sagittal axis until opening purposely the cavity, and then one finger will be placed within the endometrial cavity, 1 centimeter incision from the endometrium and 1 centimeter incision from the serosa, and all the adenomyotic tissue in between is excised. And then the reconstruction here, we first close the endometrial cavity. For the overlapping technique, as its name suggests, it's like a palto technique. And here they are using the scalpel to refine and refresh the edge for better healing. However, on the triple flap, 2 flaps, one anterior-posterior, and then the contralateral comes on the top to cover it. We do extrapolate these techniques that were described by the Japanese in laparoscopic practice. And you can see in the 2 cases how bulky is the uterus. We bisect the uterus in the upper one, we bisect, it is the same as shown in the laparotomy, while on the lower edge of my screen here, it's inverted diamond shape. It is an elliptic incision, which was incised back to the uterus. And then we progress in a conic shape towards the cavity. And then we, as its name suggests, it is a cytoreductive surgery. It's we are not aiming to remove everything because the disease here is diffuse, involving all the uterus, making sure not to open the serosal flap on the other side. So we'll be able to reconstruct and not to alter the interstitial portion of the tube. And the reconstruction here on both cases were the same. On the lower one, we used Vacril. These Vacril were from the first cases, and the upper video are using barbed suture, the Stratafix, and we are closing in palto technique or overlapping technique, aiming to fill up the dead spaces as much as possible. You can note here how difficult to bring the 2 edges together because the wound is not symmetrical. The disease remains at the edge. There is a lot of strain on the tissue, and there is a forced reconstruction. And this where is the challenge in this type of treatment. And we end up, of course, the surgery by putting anti-adhesion material. He is Intercede. So another case from our series, she was just 34 years old who presented with the full package, dysmenorrhea, dyspareunia, menorrhagia, and primary infertility with failed IVF. At first, this patient was diagnosed as fibroid elsewhere, but luckily she came for second opinion, and you can see the significant asymmetry in the uterine walls in both sagittal and axial cut. In patient desiring fertility, our assessment always starts by hysteroscopy, looking for concurrent pathology, which is frequent in this patient. So here we look at the hysteroscopy, and we have obviously the indirect sign of adenomyosis, which are the crypts. There is obvious stretch at the funder, and there is obvious deviation of the cavity due to the bulk of the posterior. Keep in mind that this type of surgery, it is bloody surgery. They bleed a lot. That's why all precautions should be taken beforehand, before starting any surgery. So here we did the uterine artery ligation at their origin, and then we used vasopressin, and then the first incision was using monopolar hook, and then soon we realized that it is a diffuse adenomyosis of the posterior wall, so we shifted to the cold knife and as an extirpation tool, and you can see how much we removed, but still there is more of it. And you can note that that we are not complete in our excision, but we have to stop, keeping in mind that this patient is only 34 years old, aiming to get pregnant. So we have to keep some myometrium for reconstruction. The endometrial cavity is closed separate using monocril 2.0 without passing the suture within the endometrium. It's like burying the opening. And then here we put Surgicel, hemostatic material, and you can see the final view. At the end, we end up our procedure with hysteroscopy to look if there is any suture material, and still we put anti-adhesion hyaluronic acid gel inside the cavity. This patient had 6 months of GnRH analog with ADVAC therapy, and that was her MRI 6 months after the surgery and the treatment. You can see that we restored the three signal on MRI, myometrium, junctional zone with symmetrical appearance, and the hypersignal, which is the endometrium. Just a reminder, that was her MRI before surgery. Another patient, which is the sister of the previous patient, but this patient, 37 years old, her main concern is the fertility, not much of dysmenorrhea, not much of menorrhagia, but main complaint is that she couldn't get pregnant and she couldn't afford IVF. On the MRI, you can see obviously retroflexed uterus with a torus deep infiltrating endometriosis continuing upward towards the myometrium by significant diffuse adenomyosis. We go in, there was a lot of work before tackling the adenomyosis. We had to open both pararectal fossa on both sides, lateralize the ureter, the nerve, suspend the ovary and drain them from endometriosis. And then we started by our precaution to prevent intra-op bleeding, uterine artery clipping, vasopressin. In adenomyosis, we purposely and intentionally keep the MRI in the OT in order to guide our dissection. Here we were a little bit tempted by the luxury of the ultrasonic because, as I said, it was a lengthy procedure. We had to do a lot to reach the adenomyomectomy. Again, I said in patients who are desiring fertility preservation, it's a must to have MRI. I know that the recent study showed that ultrasound, when performed by expert, can reach the same level of specificity and sensitivity as MRI, but we still believe that MRI with a more objective view can offer more information. And that's why we look at the image, because in fibroid, we have a capsule that will drag us for a complete enucleation, but in adenomyosis, we don't have that cleavage plane. So we keep the MRI in the OT to follow the direction of excision or of extirpation. You see here that on the top, we had a diffuse adenomyosis continuing downward with a focal lesion, that this is the one that we were now enucleating, and torus nodule downward. This patient also, she had bowel plaque at the rectosigmoid junction, but we abstained from doing any resection as she had a very big surgery, and we did just a simple shaving. As said in the beginning, we were mainly using Vicryl and monocryl to cover the opening of the endometrium, and in this case we used the Vicryl mattress suture longitudinal axis for a double layer closure. And monocryl has the advantage to slide easily through specifically such tough tissue. This is the torus nodule and the vagina was open. That's why we did a simple shaving on the bowel endometriosis. So the good news came soon after this surgery, and the patient achieved a first spontaneous pregnancy. And we were closely monitoring her until she reached 33 weeks, when she started complaining of a vague pain. So safely, we did her cesarean section electively, and I had the chance to be in the cesarean. And obviously, the posterior wall was very thinned out with a defect. When we do what we call uterine revision and we clean, there is obvious defect on the posterior wall. 18 months later, she got another spontaneous pregnancy, and she had elective cesarean at the 33 weeks. So at 37 years old, after the surgery, this patient had 2 spontaneous pregnancy. Another case here, the main concern was fertility, 10 years of secondary infertility with the MRI as shown here, a focal lesion on the posterior wall of the uterus covered by the ovary. Intra-op, we find exactly, that's why I said the MRI offer more realistic and more objective images. We find that the ovary is sealed over the adenomyotic lesion, and we have the tube looping around. Not much of adhesion in the pelvis. The ovary were looking good, and you can see the lesion that we tried to sculpt it for a complete excision. And this patient achieved a spontaneous pregnancy, also 3 months post-op. However, and unfortunately, at 22 weeks, fetal heart disappeared, and we had a high suspicion of placenta accreta at the site of the excision. Here, our excision was exactly at the left posterolateral wall, and the placenta adherent to that area, and we confirmed that with MRI. We did a hysterectomy at 22 weeks to deliver her. Some of the placenta was left behind, for which she received methotrexate, and then it got resolved. Later on, patient had another spontaneous pregnancy, and she had elective cesarean at 33 weeks. As nowadays, it is possible to remove a FIGO 1 and up to 2 of submucous myoma. And this is the experience of Professor Rudy, who gave me this video. So in the setting of outpatient, they are able to excise a lesion on the subendometrial with a pre-treatment of JNRH. Reducing a little bit the intrauterine pressure that will allow the lesion to bulge. Obviously, you have to allocate preoperatively the lesion because, as said, you don't have the capsule or the fibroid that will show you, and the tissue in general it doesn't show clear difference when it is diffuse adenomyosis. So you see here, when we're using the mini resectoscope, the subendometrial cyst was draining a chocolate material, and they have a successful story following this type of treatment. So when the lesion is bulging within the endometrium, hysteroscopy can be a helpful tool in diagnosis and treating such a small lesion, less than 4 centimeters, in outpatient setting as well. So coming now to the outcome of this uterine sparing surgery, and this is the experience of Professor Pistofidis. And you can see that grossly we have two main phenotypes, the diffuse and the focal lesion. The diffuse, when it is affecting the whole uterus. The focal lesion has 3 phenotypes or subtype according to the consistency and the texture of the lesion. Scleral, when the texture resembles more to a myoma. Nodular, when the lesion resembles more to a deep infiltrating nodule. And cystic, when the content is like endometrioma. So in cystic and nodular, the conservative treatment was complete, near complete in the sclerotic form. However, in the diffuse form, they had to go back in 80% to do a hysterectomy. Regarding the combination of surgical and post-op medical treatment, this is what we are following. This paper from Taiwan, and they compared 2 arms. 114 patient had the combination surgery followed by medical treatment for 6 months, and versus 51 patient who had surgery only. They found that when combined to the surgical treatment, the medical can result in lower relapse compared to the surgery only. This is a systematic review which looked at 64 patients with 1,000 patients, complete versus excision surgery. For the dysmenorrhea reduction, the 2 groups, they showed the same result. However, in menorrhagia control and the pregnancy rate, the complete excision showed higher rate and more effectiveness. Always in the fertility outcome, and this is also from Denmark, where they looked at 338 patients who had surgical conservative treatment for adenomyosis, and they looked at the fertility outcome. Obviously, some of them got pregnant spontaneously, other they needed assisted reproductive technique, and they found that the pregnancy rate has reached 47%. We do even report higher rate. Till now, over the past 7 years, we have recruited 48 cases of laparoscopy, a few only hysteroscopy, and we have a pregnancy rate of 60%. We had a patient who had more than one successful pregnancy. We had IUFD, we have uterine rupture, we have preterms, we have almost all the obstetrical outcomes with these patients. However, the data supporting this type of treatment is still suboptimal, and you have seen how mutilating is this type of surgery to the uterus, and not only this, it is associated with very heavy consequences and obstetrical repercussion. And uterine rupture following adenomyomectomy can reach up to 6%. And in 18 published studies, it has been demonstrated that uterine rupture following these cases is associated with high risk of hysterectomy, up to 30%, and significant blood loss and massive blood transfusion. And we lived the nightmare with one of the patient. This patient had a long journey of infertility with multiple failure. She had 3-compartment endometriosis, bladder endometriosis, diffuse anterior wall adenomyosis, and bowel endometriosis. So in one surgery, she had 3-compartment surgery, the bladder endometriosis, cytoreductive surgery of the anterior wall of the uterus, and segmental bowel resection. So after the surgery, she got pregnant spontaneously. However, by 25 weeks, she had uterine rupture and she lost the uterus and the baby, unfortunately. So you can see here the diffuse aspect of the disease on the anterior uterine wall, retracting the tubal ostia anteriorly. The reconstruction was very challenging because you see, despite using big needle, but there is a significant strain on the tissue and the disease remained on the edges. And it was difficult to cover all this gap. As said, unfortunately, she couldn't fulfill her dream and we had to do hysterectomy on her. So when usually does it occur, this uterine rupture? A little bit around 28 weeks. It is silent, unpredictable. And one of the most plausible hypotheses is that after adenomyomectomy, the uterus becomes small and irregular with diminished capacity. Moreover, the high progesterone state during pregnancy may lead to disutilization, which is the precursor of infection and weak uterine wall. This is a case report and literature review where they reported the case of uterine rupture after adenomyomectomy, and they looked in the literature and found that 5 out of 6 uterine ruptures occurred after laparoscopy. So the laparoscopy is considered as a risk factor for the uterine rupture, and we have to admit that there is a recognized difficulty and limitation of this approach. We lack the tactile sensation, and we cannot really define the volume and the extent of the lesion or the boundary between normal healthy tissue and diseased tissue. The extirpation tool or technique plays a major role. And as said, we are sometimes stunted by powered instruments, especially in lengthy procedure. And the capacity of suture is limited, a lot of strain. You have to bring asymmetrical edges over a dead space or a gap. That's why surgeon experience here is of a pivotal role in the outcome of this surgery. OSADA has made or conducted an extensive histological research on the influence of electrosurgery on the tissue healing, and they found that when we use the powered instrument, we have more wound heal disturbance and instability, which may lead to dehiscence. And in the reported 23 uterine rupture in their series, they found that 15 out of 23 rupture occurred after the use of powered instrument. However, when they used the scalpel, there was no rupture. So which approach should we favor in these patients? There is no clear evidence. We have to keep in mind that we don't have a large randomized trial regarding this type of surgery. All the data we have are retrieved from a small case series, and there is no clear evidence favoring one approach over the other, and the advantage of laparotomy remain theoretical. So here we join the theory of Nejat and co-worker who believe that the combination of the laparoscopy to tackle deep infiltrating endometriosis, to do the hemostasis, and the mini phalansteal for a fine excision of adenomyosis and better uterine reconstruction may be better for the patient. And despite we have a large experience on this, but we remain humble. And when the patient benefit is better, we still do few laparotomy for adenomyosis. Special attention should be paid for patient who gets pregnant after adenomyomectomy. Pregnancy should not be attempted at least before 6 months. We have to give them a reliable contraception, and GnRH could be a good option in this case. And it has been demonstrated that in extensive cytoreductive surgery for adenomyosis, the resumption of blood flow is noted up to after 2 years after surgery. So it takes 2 years to get the vascularization back on that muscle. So obviously, it's a very challenging condition in patients requiring fertility preservation, and the quality of pre-op diagnosis matters a lot. We have to integrate all what we have, surgical, medical, and assisted reproductive technique. It is a new challenge, as I said. We still have limitation. We still need a lot of learning curve, and we need to evaluate what we are doing right now. Assisted reproductive technique is closely associated to surgery, and always other factors should be elicited and discussed and put on the table. Probably surgery can be applied on focal form. However, the cytoreductive surgery only if repeated assisted reproductive technique and failure of medical management. And we have to keep in mind that it has been demonstrated surgery has no impact on a fertility outcome in patients above 40. Keep in mind it's not a cancer, so radicality will not be always possible. And for diffuse form, really the best approach, we don't know yet what we are doing. Is it the correct approach or no? Thank you for your attention.
Thank you, Anan, for this overview, which is quite interesting. Yes.
Thank you.
We are.
So, I want to ask about now. We are some surgeon some infertility doctor try to avoid resections of adenomyosis and doing radiofrequency or HIFU. What is your opinion about that? What is preferred?
You understand the question, Anan?
Yeah, understood. Unfortunately, we don't have the facility of radiofrequency, but I know that there are published data about radiofrequency in China, and it has been demonstrated that most of them gets pregnant after that, but we don't have experience with that. And this is, I think, the only data came from China. HIFU also, but we don't have experience with this. So either IVF, XC, down regulation GnRH, or surgery. Focal, we don't hesitate hysteroscopically or laparoscopically, especially in the setting of deep endo and the disease of the outer myometrium, we excise. But we are a little bit reluctant when it comes to diffuse form with multiple failure. Then we discuss. We discuss with the patient, with her fertility doctor. We consider other factor, the AMH. So the cytoreductive surgery, it's not, it's in the diffuse form is not our first line treatment.
Yeah, I think the problem is not too much the technique, so IFU, whatever, radiofrequency or surgery. The problem is the type. So I'm not sure that IFU and radiofrequency will be better for diffuse form. So I mean, I have some doubt for the mechanism.
And
but we can try. Huh? Everything should be. Yeah.
Yes. Do you mix the? Hello, Anan. Thank you for your talk.
Hi. How are you? How are you?
Do you use sometimes both technique, GnRH and surgery? And if you do it, how long do you put the generash before surgery?
Before surgery, not really, but in general, the diffuse form, they come after multiple failure of IVF, after multiple protocol of down regulation, then we go for subthyroid. But post-op, yes, we put them. Post-op, we put them for 6 months. The focal, in general, 3 months, and we have patients who got pregnant after 3 months from the excision of focal adenomyosis.
Okay. Okay, thank you, Anan, for this nice
Thank you.
lecture. Be
Thank
well,
you.
but you are in my
Thank you
office.
so much, Professor. Thank you, everybody. Yes, I am in your office.
She took my place. Okay.
Nobody can take your place, Prof.
I come back. When I come back, I take it back. Huh? Okay.
Sure.
See you.
Thank you,
Bye bye.
everyone. Thank you.
Bye bye.
Thank you. Bye-bye. Bye.
Okay, so let's move on and let's come back a little bit on bowel. We have seen that yesterday. We have seen a little bit today. But let's cover the subject. Isvan will cover the if we know when to do shaving, when to do discoid, when to do segmental, and how to do it. And then I think a very important topic for you all is we know, and this is probably what we have done the best recently, is we have understood the rationale of our complication, and we have developed some technique to prevent it with this. Isvan, thank you.
Thank you so much. I will mostly speak about different techniques what we can use in bowel endometriosis. As you know that 5 to 12% of the endometriosis cases can have bowel involvement, and you can see that it's mostly 65% is in the rectum or the rectosigmoid, 17 sigmoid colon, and you can see that it can also appear on the appendix and circumiliacal junction. It's very important to understand the disease, to have some information why we have a different kind of symptoms. So that you see that due to the muscularis hypertrophy, you can have some rigidity in the bowel segment. The retraction can cause the stenosis of the lumen, but as the mucosa is most of the time is totally conserved, so that's why we can have a normal endoscopy even if there is the disease. But even you have a nodule like this, you can have some remaining elastic part. So this can be that we don't have symptoms or not typical symptoms, even if we have a nodule. When we are speaking about the symptoms, there are some non-specific symptoms related to the disease itself, dyschizia, diarrhea, tenesmus, retroregia. And then we start the pre-operative workup, and we have to answer most of the questions before we start our surgery. So how many lesions there are present? Is the lesion responsible for the symptoms? How deep is the lesion? What is the size of the lesion? What organs are involved? Because as you know, if you have multiple compartments involved, we can increase the chance to have a complication. And then what will be the digestive function after the surgery? It's very important to discuss with the patient all the outcomes, what is possible we can have, and what has the patient consent for. Important. So clinical examination, most of the time, 40% of the cases are reported normally. Obviously, we have limited information for depth, and we have limited information in some locations. So, normally, what we do is important for us to have ultrasound, MRI, and colonoscopy. Yes, no, I told you why not, because the mucosa most of the times is intact. So when we are speaking about the transvaginal ultrasound, generally we can say that the transvaginal ultrasound is a quite easy, accessible tool, But when we are speaking about these ultrasounds, it's not a regular transvaginal ultrasound. This needs a highly trained team and the preparation, so it cannot be performed by everybody. And obviously, it has some limitation. You cannot gain some information above the rectosigmoid junction. And also, it can be limited to give you the distance from the anal verge. When we are speaking about the transanal ultrasound, it's quite a good tool to get information from the distance from the anal verge. It can cause some discomfort for the patient, so we don't recommend it that often. MRI is a quite good tool in the preoperative workup. We can get information from, regarding the size of the lesion, the depth of infiltration, and also we can get information from the distance from the anal verge and also from different organs involvement. I mentioned the colonoscopy is not always important for us because the mucosa can be intact. It's very important that when we are dealing with the posterior compartment endometriosis, before we start, we always have to check the ureters because ureters can be involved, and 70% of the endometriosis cases leading to hydronephrosis, they are associated with rectovaginal nodule. So after we did all these examinations, we can get information from the localization, the size, and the depth of infiltration, and also if there is a stenosis, yes or no. The question is it enough to decide prior the surgery what kind of technique we will use? And the answer is no, because the technique will be defined or selected at the time of the surgery when we evaluate the situation. As you know that you heard during these days that due to the disease we have anatomical distortion, the ureter can be medialized, there are some adhesion, fibrosis and inflammation due to the disease. So we have to try to do complete surgical excision of the lesion, but we also have to remember that this is not a cancer. So we can only do what we discussed with the patient, and that's why it's very important to have a clear description of the possible outcomes and give all the information for the patient before we start the surgery. Let's start with the rectovaginal nodule. The strategy in the rectovaginal nodule, first of all, you make the detachment of the sigmoid. Then you will suspend the ovaries so you can keep your assistant hand free. First you go on the left side, you can get access to the pararectal fossa on the left, then you take the pararectal fossa on the right, and then you can attack the nodule itself. Here you can see, if I have you can see the nodule, os fossa are dissected and you reach the healthy tissue. So after that you go directly and you try to detach the disease by using a cold scissor. We have different techniques in bowel endometriosis, and even if we have sometimes difficult cases, we have to say that laparoscopy have taken over laparotomy in the treatment of endometriosis, even if we are having sometimes not just these kind of patients, but also a little bit more difficult patient with obesity. We have conservative treatments for bowel, and we have more radical treatments. You can see artificial lysis, shaving, and mucosal skinning, and radical treatments can be an anterior resection, discoid resection, and segmental resection. Depending on the layers of the bowel, we can make a shaving, we can make a mucosal skinning, and we can also make a full thickness resection from the wall, which is the discoid resection. So let's start with the shaving technique. So this technique, it's very important that the superficial disease is dissecting from the bowel wall without trying, obviously, without trying to enter into the lumen. Dissection cranially to caudally, using cold scissor. We have to be very careful with the coagulation. So if you use the bipolar, it has to be short burst not to burn the bowel wall. And if you have to reinforce, you will use a 3-0 reinforced transverse sutures. Discoid resection is the anterior resection of the bowel segment using transanal circular stapler. We have the following steps. So if your nodule is quite big, which would not fit in the gap of the stapler, you start the procedure with the debulking the nodule. You try to make it smaller. So you start with the initial shaving. So you make the nodule a little bit smaller. That will help us to put the nodule into the discoid, into the circular stapler. After that, we will place a guide suture to the disease. This guide suture will help us in the next step. As you can see that the stapler is placed transanally, and with the two suture, you are holding the two suture, and when you open the stapler, the two suture, the guide suture will help you to place the disease exactly between the two jaws of the circular stapler. Then you close it, make sure that nothing is between before you shoot it, and after shooting it, you have to make sure that the specimen is correct and you have the full semicircular specimen. There are some publications about the double circular technique, double circular stapler technique. So if you have a big nodule, you go with your stapler, you take one shot, and then with the second stapler, you take the remaining disease and the stapler line of the previous one. Even if this technique is published, there can be some stenosis, so high risk of stenosis in these cases. There is also an article which what is interesting in terms of little bit saving, because a lot of hospitals are struggling with the financial part. These instruments, these staplers are quite expensive. So there can be an alternative when you do an excision and you suture it with the hand. In terms of complication, the number of layers or the suture material which has been used, it doesn't make a significant change. What is the limitation of the discoid resection? Obviously, if you have a high lesion, what you cannot reach with your circular stapler. Obviously, there is another limitation when you have a stenosis, so you cannot push through your circular stapler. Or if there are multiple lesions, this is also a limitation for this technique. In these cases, we can perform segmental resection. So indication for segmental resection: if there is a stenosis, you cannot push through your circular stapler. If there are large multiple incision, or if there is a significant injury. This picture is very important, where it started and where the technique is going towards to being very economical. We have to remember that this is not a cancer, so you have to minimize the resection and the removed bowel to keep the function, because these are young ladies and this is not a cancer. So the surgical technique for bowel resection, it's very important for us that inframesenteric artery and vein preserve their enterity. Depending on the involvement of the disease, the middle rectal artery can be sacrificed. And here you can see in colorectal resections, when you do the mesenteric artery ligation, you can have some problem later on with dysfunction. So as this is not a cancer, the mesenteric artery should be preserved. I mentioned before that this is not a cancer. These are young patients, so we have to pay attention on their bladder, the rectal and sexual function as well during the surgery. So we will use the transmesorectal space, and for this dissection, the ligashore device is quite a good choice. The lateral thermal spread is quite low, so you can go very close to the bowel wall without hitting it, without burning it. And you can see if you go, if you do the dissection, the mesorectum, you can preserve all the vascular and nerve supply. You will have a better function afterwards, and you can really make a limited resection. How you prepare your anvil? You are cutting a tube the same length as your forceps. Then you take the anvil. You will knot a suture on the anvil, and then the anvil will be ready to backload into the tube and will be ready for insertion transanally. Obviously, for this technique, if you have a big stenosis, you won't be able to place your anvil with this technique. So this can be a limitation. Now the anvil is ready for insertion transanally. And then when you push your anvil up, it's very good always to have an internal view and to help with the laparoscopic instrument to position the bowel in such a way that you can push the anvil a little bit easier up, not making any perforation on the bowel wall. After the anvil is placed, you will do the bowel division. For some of you had the chance yesterday to try the linear stapler in the lab, so I think it's quite a good experience to try it on animal model. And after that caudal bowel division, as you can see that we can close the bowel with the hook, and as this part will be removed, it's not a problem if you open the lumen with the ligashore, because these burnt edges will be removed later on with the linear stapler. You see that with the T-lift, we keep the rectum open because we will remove the specimen through the bowel. Here you can see the specimen removal. And after that, with the linear stapler, you will close that bowel part. Distal closure. Also, if you have an opening on the vagina, there is another way to extract your specimen. You can extract the removed specimen through the vagina as well. Obviously, after the removal, you will close the defect. There are two ways, or even more, but I will show you now two ways how you can remove the anvil from the bowel. First technique is when you take two grasper and with the mechanical force, you are pushing down, waiting until the edge of the anvil will come through on the bowel wall. It's better to do it like 1 centimeter, 1.5 centimeter away from the stapler line. After that, you remove it and you will fix it with the endoloop to keep the correct position. Other technique is the fishing technique. When you're using a monopolar hook, make a small hole, small opening on the bowel wall, and using the hook, try to get the thread, which has been fixed to the anvil, and by pulling out, you will remove the anvil from the bowel wall. When the anvil is placed correctly, fixed with the endoloop, next step will be to do the mechanical reanastomosis. For this, you will insert the stapler transanally, you will open it, and connect the two pieces. It's very important before you close it, you have to make sure that there is no rotation, the length is enough, you don't have to mobilize more. It's important that the anastomosis should be tension-free. It's very important. So you make sure that the bowel segment is in a correct position, no rotation, no tension on the suturing line, and then you can shoot it. If you remember, 6.4% of the cases we have also some appendix disease. So I think it's quite an easy technique, using and knowing the right instrument. So again, LigaSure can be a very good option. You can go close to the wall without burning it. And after the preparation with the 1 or 2 endoloop, you can close it, and you see it's quite a fast, efficient technique to make an appendectomy. You pull it through, you close it with an endoloop, you put 1 more endoloop, and then you remove it. So the nose technique, just a few sentences about the nose techniques. Nose technique, even if it seems to be very minimal invasive, without any scars, but look, if you have a stenosis, you have to pass above the stenosis to insert your anvil. So in these cases, maybe we should prefer to have a transabdominal technique, the classical technique, and to retract the affected area. Why it's not running? And make place the anvil. Sorry, wait. So you make a small incision, you retract the bowel, and you will place the anvil outside, and then you do the reanastomosis laparoscopically. I think with this technique, it's better to use if you cannot insert your anvil, because you saw in the previous picture that the nose technique has obviously some limitations. What is important is we have to be economical, because this is not a cancer. We are dealing with young patients, no comorbidities, no vascular disorders, and the desire for childbearing. We have to avoid long resection, because we are working towards limited resection, which is really limited for the disease. This is very important. Here you can see, I just placed this video because this was a second look laparoscopy after frozen pelvis with bowel resection. You can see with the good surgical technique, with the correct technique, you can almost restore the total anatomy. The only place here you see, there was an omentoplasty there, so you can see the place of the omentoplasty. But beside this, we can say that the anatomy is totally restored, and even it was a quite extensive surgery with the frozen pelvis. The results is excellent. Just a few thoughts about a paper of the Strasbourg team. Risk of recurrence. From this study, 18% of the patient underwent further surgeries for recurrent lesions. And in the shaving group, it was higher, the recurrence rate, compared to the segmental resection group. Safety test, it's very important. As you saw, Professor Ferreira, during the live surgery, he performed also the safety test. It's very important. Whenever we are doing bowel surgery or bladder surgery, we have to perform safety test, or we do the gas test. No bubble is okay, obviously, or we have the bubbles, we have to repair it, or we can have the methylene blue test. There you can see that during the shaving, we remove the part of the mucosa. In these cases, you have to reinforce the defect with some 3-0 stitches to avoid complication. Also can be an option because in this paper you have it's feasible to have intraoperative endoscopy, because obviously with the gas test and the blue test you cannot check the integrity of the anastomosis. So it's quite feasible and fast to perform intraoperative endoscopy to make sure that the stenosis has good integrity. Also an option can be to use indocyanine green to judge the quality of your anastomosis. We have to remember that the lower the anastomosis, the higher risk you have for a leakage. More common an anterior resection lower than 7 centimeters from the verge. Why is important for us to do the safety test and to follow up the patient correctly postoperatively? Because after 24 hours, the mortality can go up to 22%. So it's very important to get prepared for this situation. We have to remember that we have to be radical towards the disease, but as the young patient, and this is not a cancer, we have to be conservative towards the function. As I told you again, we are operating benign disease with young patient, and the goal is also the fertility preservation. Thank you for your attention.
Thank you, Isvan, for this lecture. Any question on that? Or alors, as is a bit a sensible subject, because for many reasons, because my feeling is that the decision between shaving and discoid or segmental is not very clear and depends on teams. My feeling is also that probably too many bowel resections are done sometime. Just to tell you, in my experience, we do for bowel endo a little bit less than 20% of bowel resection, when some team does 94%. So, I mean, the difference is significant. So we 94, 95%. Yeah. So and then the second point is we are gynecologists, and some of us does the job, the bowel, depending on your situation, privilege, and competences. And so we are, and even in that case, you know, when you have a complication, bowel complication, as a gynecologist is always more difficult than if you have a complication as a colorectal surgeon. So we have to minimize the risk of complication, and we learn that. So Boris will tell us how can we do to reduce the complication.
I will try. Yeah.
Thank you.
Good morning, everyone. Thank you, Professor, for the invitation. So the topic I will talk about is surgical technique to prevent complication after bowel surgery. And why this is important, as it has been repeated many times during these 3 days, it's a benign disease. So we must aim to really reduce the amount of mortality and morbidity, and it affects young, healthy persons. So first we need to identify the factors, and these are mainly two of them. Firstly, the nodule or the disease itself, its size, where it's located, which position it occupies in the pelvis. And the second factor, which is much more difficult to control and deal with, but this is why you're here to these 3 days lectures, it's the experience of the surgeon, because as we speak, there is no consensual standardized technique to tell us exactly how to deal with the disease, especially when it's located on the bowels. So the complication we are talking about are two main, obviously, dreaded complications, the fistula and the leakage from the anastomosis, but also the anastomosis stricture, the abscess in the pelvis, and post-op bleeding. But we will mainly look at the fistula and the leakage. So the definition is represented here, and we can classify them between small, medium, and large, and usually they will appear between 5 and 2 weeks after the surgery with some very easy to identify symptoms like abnormal malodorant vaginal discharge. There was a meta-analysis from an Italian team looking at all the complications after bowel surgery. There were retrospective and prospective studies. And what we've identified in terms of risk is mainly the fact that if you've got a concomitant opening of the bowel and of the vagina, this is definitely a very important risk factor, but also the technique. And we know that resection carries more risk than excision, and shaving in this respect will be the least procedure providing complication. However, it will keep or it will remain more disease than if you do a resection. What about leakage? Again, the symptoms are very well identified. And this is where a drain sometimes can be interesting because you can identify gas or you can identify pus in your drain. It could be complete or it could be a simple dehiscence. The diagnosis, I think, in emergency situation, most of the hospital will do a CT scan. And one of the main risk factor is the position of the anastomosis. And then when it's ultra low, which is less than 5 centimeters from the anal margin, this is when you've got most of the risk of leakage. How do you manage that? Usually as gynecologists, it's very rare we're going to be on our own, and we're probably going to ask the bowel surgeon to decide what to do. So it could be doing an ileostomy or just closing the small leakage, or sometimes we do a colostomy and we do the reanastomosis at a later stage. I've mentioned stricture before. So strictures have been defined by an Italian team as the difficulty to pass a 12 millimeter proctoscope, and two of the symptoms that are mentioned here, so constipation and ribbon stools, tenesmus. But fortunately, the treatment is quite easy, and in their series, they got a good outcome in all the cases by just repeating the endoscopic dilatation. Other complication could be pelvic abscess, so we need antibiotics, we need washing, going back and making sure we've got a good hemostasis. And sometimes you can have bleeding on the area of the anastomosis, and this is mainly with discoid resection. So in this picture you can see, you can apply a staple just there. So we have identified the problems, and now we need a strategy to try to overcome this issue. But if we use the tools and the technique, we need to make sure that they provide, or there is evidence to provide their use. So the first one will be detecting, before the surgery, identifying who is likely to need a bowel surgery and do a bowel preparation. And the evidence for that topic does exist. There was a Cochrane review in 2023. And you could see that if you use a medical bowel prep plus oral antibiotics, then you've got a reduced level of site infection and leakage. What about leakage? How can we prevent that? So we've discussed that yesterday. We need to reduce the apoxia of the anastomosis area. We need to have a good vascularization that can be tested with ICG. Now, this is still open to debate, as we discussed yesterday and actually earlier this morning. But I just wanted to show you two randomized trials in 2020. Sorry, and you could see that one team found that it was helpful, and the other team didn't find it very helpful. Something we've mentioned before is the tension of the anastomosis. Too much coffee. And so the tension is another factor that we need to control, either by doing a very high mobilization or sometimes, as it was also explained yesterday, by reinforcing the suture. What about the use of a drain? Now, that is a controversial issue. Different surgeons use it and systematically, because it will allow to prevent the accumulation of blood and serotic oozing that could become an abscess, that could become infected. But also you can detect abnormal discharge and early identification of anastomosis. I haven't finished. And otherwise, it will also allow you to monitor any potential bleeding and do an early reintervention. However, there is some Cochrane review and evidence that it doesn't really prevent leakage from your anastomosis site. And there was a French team which actually found that it could be detrimental in many cases, because this foreign body could promote the risk of an abscess and leading to a fistula. So again, this is the experience of the surgeons and the usual practice that the surgeon feel confident with. However, there is definitely a test that has been mentioned now many times today and yesterday, the leak test or the gas test and the methylene blue test that can be used to identify the leakage and allow a very early prompt identification and repair. So you could either just suture the defect or redo an anastomosis, or actually perform straight away, because you can see the bubbles, perform a stoma. And in that case, there was one theory in the literature where there was no post-op leakage following that. So there seems to be a consensus about the use of this test. What about using a defunctioning stoma? So in the French College of Obstetricians and Gynecologists in 2017 have ordered a group of experts to publish the guidelines. Most of the people in this group that wrote the guidelines were actually bowel surgeons. And their conclusion was, when you've got a low rectal anastomosis, regarding even with or without an opening of the vagina, they feel that you need to do a stoma because it will have a protective role. However, they then mentioned the fact that all their data and all their conclusion was based on cancer patients, and therefore they didn't really commit themselves, and they say, we're not sure if we can extrapolate and use this data and this recommendation for young, healthy women. Before 2017, actually, there was one French team that did a randomized trial, and they look at the amount of leakage and fistula in their series. And they found that if there was a mid-rectum without, a mid-rectum with colpotomy or a low rectum anastomosis without colpotomy, their series or their results show that a stoma wasn't necessary. On the other hand, they found that when there was a colpotomy and a low rectum anastomosis, they feel that probably there was a reduction, but that could not eliminate any risk of fistula. And this is mainly because there was less fistula in the group with stoma. However, it wasn't statistically significant. So as very often in our practice, we look at our scientific society and check what they've got to offer as a recommendation and guidance for our practice. And in our case, the two main societies are SG and ESHRE, as mentioned by Alberto earlier today. And what they say in their recommendation is that a stoma may temporarily be created whenever there is a concomitant opening of the vagina and a bowel anastomosis. They also say that they recommend the use of a drain whenever we do bowel surgery. So that goes a little bit with against what I said earlier. And to finish on the stoma topic, in 2020, there was a French team that published their behavior regarding stoma in 2 groups and 2 periods of their practice. So the first period was for approximately 10 years, and they call it the liberal practice, LP. And during this period, they were very keen and they were doing a stoma extremely often for any bowel surgery. And when you look at the level of fistula, in the group with no stoma, you get 10%, and in the group with a stoma, you get 7%. So there was no huge difference there. However, after the publication of the French guidelines, they decided that they will restrict, in this the restrictive period, the use of stoma, and they only did it when there was a low bowel anastomosis with opening of the vagina. And the result was more or less the same. So their conclusion was that, well, it doesn't really matter, and if someone is bound to get a fistula, even if you do a stoma on a low rectum anastomosis plus opening of the vagina, well, a stoma is unlikely to really completely prevent that. Obviously, this is open to debate. And they also pointed out that a stoma has got complication, bleeding, leakage, risk of hernia, which will impact very, very importantly on the quality of life of the patient. What else can we try to use? We can use the ghost ileostomy, which is an old concept from the bowel surgeon many years ago, but has been tried to be reactualized recently. So what you do is at the end of the surgery, you take a loop of the bowel that you suspend through the skin. And if there was any sign during the first 3-4 days of leakage, then you will have a bowel ready to perform an ileostomy. Omentoplasty has been mentioned a few times early on today. Omentoplasty has got the advantage, obviously, of providing a plug and that will separate the two lines of sutures. And also it will bring vascularization, angiogenesis, that will help to heal the anastomosis area. However, there were some theories in the literature that contradict themselves. So in 2010, there was a team showing all the advantage and finding it very, very helpful. But there was some systematic review later on that really underlined the fact that it didn't make any difference. So they also pointed out the fact that when you do an omentoplasty, sometimes it's difficult to mobilize the omentum. And when you do a second look, or when you go back in by laparoscopy, it will obliterate your patch of Douglas totally and making further surgery more complex. So there are some alternatives. One of them is to use the mesosigmoid, and yesterday we've seen some images and film about that. So rather than using the omentum, so here you can see the vaginal line, and you can see the anastomosis line. You identify the mesosigmoid. Obviously, sometimes it's a bit short, and you need to mobilize a flap of the mesosigmoid that will allow you to cover that line. Here you dissect it a little bit more, and you can see that now the mobility of this flap is satisfactory, and you pass your stitch in order to cover your line. So that was using the mesosigmoid. But what you can do is you can use the mesorectum as well. So what we call the mesorectum is not a meso in the proper anatomical sense, but it's the fat that surrounds the rectum that again can be easily mobilized, especially when you use a transmesorectal technique. And you can cover your suture line this way. And a team in Paris found that you can use the peritoneum covering your bladder, that you can then interpose in between the vagina and the bowel. Now, I just wanted to say a few words about the technique of shaving, because so far we have recognized that bowel resection or discoid resection will offer the best guarantee in order to avoid any recurrence of the disease, and shaving will guarantee a sort of less risk of complication. However, there is an Australian team that has developed a technique in order to optimize completely the shaving and ensure you take most of the disease. So what they do is they inject methylene blue, as you can see, around the nodule, and that methylene blue will accumulate between the muscularis and the submucosa. So you still stay away from the submucosa and the mucosa. So here you've got the nodule, and you take a laparoscopic injection device with a very small needle, which is roughly 5 millimeter, and you will go in a circumferential way all around the nodule, inject the methylene blue, and once this is done, you can then start to dissect your nodule, and whenever you meet the blue, you know that you are at the level of the submucosa, and it is time to stop your dissection. And this does offer, as I said, an optimization of the shaving technique. What happened after you have removed, so you can see you use a blunt technique, but also sharp technique, and you can remove the nodule in its whole integrity. But after that, you will be left with a large defect. You can see it's quite a good sized nodule. And the defect you left with will be then reassembled together by putting some interrupted suture from the serosa and the muscularis on the two edges of where the dissection has taken place. They do recommend interrupted stitches in their technique. So, briefly before we finish, some different miscellaneous topics that are open to discussion. Some bowel surgeons mainly offer to monitor CRP and procalcitonin at day 1 and day 3 after the surgery, and obviously any elevation will be an alert sign for leakage. Should you do side-to-end or end-to-end anastomosis between the two ends of the bowels? There is no evidence in the literature that one is better than the other. Some bowel surgeons also sometimes recommend the use of an intrarectal catheter that will collect any pus or any abnormal discharge and will alert you about leakage of the anastomosis area. But I found that most of the patients find it extremely uncomfortable, and really it's very rare that will last 3 days with this sort of device in this situation. And we also insisted many times over the last 3 days, but the use of hemostatic and anti-adhesion agents will probably help as well to avoid any abscess and infection that could lead to a leakage. So in conclusion, complications from bowel surgery are a real threat. As Isvan has demonstrated earlier, you can have mortality in terms of leakage between 10 to 20% if nothing is done in time, with severe physical and psychological impact on the patient. I hope I've demonstrated that there was a lot of tools and different devices you can try to use to decrease this rate of complication. Unfortunately, not all of them have demonstrated their evidence or scientific robustness to be used, except probably the use of a bowel prep or efficient bowel prep prior to surgery, the use of leak test, and there seems to be a consensus amongst all of us that when you do a low rectum resection with opening of the vagina, you probably should do a stoma as a prevention for complication. Thank you very much for your attention.
Thank you, Brice. Any question on this? Yes, doctor.
You reported one series, 10% rectovaginal fistula. In the first series and the second series, don't you think it's a little bit too high? And that the principle is that you should review your data, and when you are at 10% fistula, change your technique.
I don't think I mentioned the name of the team, but that is a discussion we already had in the past. And yes, probably before you publish that, you should review your data and compare to the rest of the teams. It's interesting because the same team then a few months later or 1 or 2 years later reported or wrote an article saying that your rate of complication doesn't really reflect the ability as a surgeon, something in this line, which was, I think, a way to respond indirectly to some of the criticisms that were raised.
Conflict of interest. No, surely 10% is too much. But the same team published 10.8% of abscesses.
All right, I didn't know this one.
Yeah, it's too much.
Yeah, but for the young people, I think it's important. What we did in Oxford, that time ago, we reviewed data every 6 months together with the colorectors, so that you have a discussion, you have a feedback of what you are doing, and if there's this kind of complications, before you get in medical legal trouble.
Yeah, but I mean, what is important on the message, because one is the problem of the post-op complication doesn't matter who you are, etc., is that if you delay the diagnosis, the mortality raise dramatically and very fast. So it means that, one, we have to implement everything to avoid the complication, that include the technique, etc. And two, we have to implement a follow-up where we detect and suspect the complication as fast as we can. And if we have any doubt, CT scan, obviously, if you can get it fast. If not, you go to the operating room and you make an early second. So that, I think this is the message. Among the techniques that seems to be admitted by everyone, this is the bowel preparation, bowel prep. And so I think that for us gynecologists that we deal with endometriosis where we have a lot of bowel involvement, not necessarily that needs resection, but maybe shaving, I think that we have to look and we have to be a little bit more attentive to the bowel preparation, which is what you mentioned, because we went rapidly, so seems to be that the best bowel preparation for what we do, low segment of the colon, is what we do low residue regimen for a few days. They say 48 hours, I say 5 days, so, but this is my recommendation. Then antibiotic started 24 hours before tobramycin and flagyl, and low enema the day before surgery, the evening before surgery, eventually repeated the morning of surgery if not clear. And so that is what we do, and I think that significantly reduced the complication. Just to tell you, because you have to look at your complication. In my team, the complication, we look at it on a monthly basis. And so actually for this type of patient, we are at 0.6% of complication all. So we are quite low because we implement all this. And so, so this is mainly, I think, what we have to retain for that. The story of the protective stoma. I think we don't do protective stoma, but we don't do also low resections. So I think so I refuse to do low resection. Question?
Oh, hello. My name's Hillary Simon. I'm actually a colorectal surgeon from the U.S. And I do a bowel prep. And I think it's just really important to be very clear how we tell the diverting stoma narrative, because stomas, and all the data shows this, does not prevent leak. It prevents the morbidity surrounding a leak. So, I have talked to lots of people and say, oh, we'll just divert the patient and then they won't have a problem. They still have a leak, and there's still a very good chance that they might develop a fistula. And to your point with the bowel prep, I believe that if you have a whole column of stool because you didn't do a bowel prep and then someone leaks and you take them back to the operating room and divert them, they're still going to have that stool in their colon. And over the next several months, as you're waiting for the leak to heal, there's still stool going by said leak. So it may prevent some of that morbidity, but the ultimate prevention of a leak, I don't, that's not the correct terminology, and I just want to make that clear.
I agree with you, because this is also what happened with the protective stoma, and so it's same. So I agree with you, but still, even if you just reduce the morbidity, I think it's good. And but I think this is a combination of all this. So I mean, combination of all these mean, which are not 100% never, that bring you to reduce at the end really the rate of leakage. And to be honest, with us, in Dubai we don't have seen a leakage since 10 years. So I mean that it should be efficient somewhere.
But you monitor also the C-reactive protein, no? After bowel surgery.
The what day?
The C-reactive protein is monitor everything.
Yeah, the story of the CRP is a bit also challenging because we have a lot of data. So it seems to be that you check, you have a baseline. So I think it's good to make it the next day because you have a baseline. So what I know from the literature is you have a cutoff point at day 3, because you say it's if at day 3 you are 60, maybe no significant, and you have a cutoff. If I remember on the data, the cutoff is 170, and then so where you have highly probably a problem. So I think it's honestly, I think clinically, I prefer to look at the fever, the tachycardia.
The patient.
That I prefer to
Also,
look
how
at
the patient
CRP.
feel.
I think those patients have to be followed clinically.
Important.
Lunch?
Yes.
Okay, lunch, and we come back at 2. I have to go. I come back.
I see that there are a few papers I should write.